Yeah, some housekeeping rules. Kindly keep unmute yourself because it is going to be a very brainstorming talk for I mean, we are not keeping the title as under five wheezing. We are keeping it a wheezing in young. So it may cover from, some from newborn to early age until 5 or 6 years also. And so I know this is important talk for most of us, for a day-to-day practice. And for delivering this talk, there is none other than Professor Subramanya N K. He's very famous, in IAP as a academician, and the way he present in any form of whether it is online form or whether it is offline. So he's very famous. He goes to the the root of the problem, and he try to explain as much as possible for a grassroots pediatrician. Actually, sir doesn't require any introduction, but I would like to some words about him. That he's a professor at Saptagiri Medical College in Bangalore, and sir is IAP NRC chapter president, as well as he's South Zone vice president, as well as he has numerous publications in Index Journal, and he's very active in respiratory chapter. Because of him, there are so many things like advanced asthma program has been started already. One batch finished, other batch is also already finished, and third batch advanced booking is also finished. So sir is very active in respiratory chapter, as you know that he's a president, and in his presidency, we have started the IAP respiratory journal, which is the one of its kind, and the first issue has been published last month itself. So with this, I think I would invite Dr. Subramanya sir to deliver his talk. And thank you so much for accepting with your busy schedule in IAP chapter, and for delivering this talk. I invite you, sir. Thank you so much.
Respected Dr. Warankar, the moderator of today's session, Dr. Hemant Gangolia, the president of Maharashtra AP, and more than that, my dearest friend, and the office bearers of Raigad, whom we are proud of, Dr. Pramod, Dr. Vikas, and Dr. Dhananjay, and all our dear, I would say, passionate of pulmonology and respiratory topics. So that's all is what I would say. There are many in the audience, very senior teachers like Srinivasan sir and so many. I can't just name anyone, but I'm just taking very senior teachers to all youngsters who have joined. So let me begin sharing. See, it's all about wheezing in young. I would say wheezing in young, younger, and youngest. If I were to tell you few things, you must have heard very popular names such as, wheezing under 5, so on and so forth. But what I would like to ask you is one simple question. Please let me know, is wheezing from newborn, wheezing up to 3 months of age, wheezing at 6 months of age, wheezing at 2 years, 3 years, and 5 years is same? Answer is no. And therefore, this under 5 wheezing is a myth. And therefore, I told wheezing in younger, and youngest. It makes huge difference. And you need to understand that until and unless you keep the age of onset of the first wheeze in mind, you will never diagnose wheezing properly. Greetings from myself. Now, I will go through some of the basics because please, those of you who cannot listen completely, please listen to this 5 or 6 slides of basics, because unless you understand these basics, the wheezing, knowledge on wheezing in young becomes totally incomplete. First of all, when it is young, confirm wheeze. When it is old, you can hear wheeze. Correct? No? Please type in the chat box. Older ones, you can yes, actually auscultate well. In adults, you can go well. Whereas younger they are, the wheeze is often not heard. And many a times we see seniors are telling, even in 6 months, chalo abhi dikh raha hai wheeze. Can you hear? When you put your stethoscope, you may not hear. That's very, very important. And remember, in newborns, when you hear, it may not be wheeze. It could be a stridor or a noisy breathing, because wheeze in a newborn is not heard. Am I clear? What I meant was the lungs of the newborn. Um, Lungs of the newborn are like, they are not like what I would say, um, um, so much powerful to push the air through the distal airways, which can be audible by stethoscope or otherwise. I think you got my point. I suppose one or two of you can type yes for me to make. One of you can type yes to me, so that you have understood what I meant by that. The lungs as a pump has to push the air through the narrow airways, that you can produce a sound. Even to produce a sound, you need a blast of air. And the younger they are not able to generate. Therefore, absence of these does not mean there is no obstruction. This is the first point I wanted to tell you. And therefore, as a corollary, you will realize that once you have a wheeze, that means there is adequate amount of volume of air that is going through a narrow space of airways. And I think, therefore, you need to confirm the wheeze, and it is difficult to confirm in young. And when you hear, please differentiate it from stridor versus wheeze. This is most important point, because somebody says wheeze onset at 20th day of life. It could be maybe larger airway sound like stridor. Okay, now all that I was, and to start with, I wanted to tell you that wheezing in young is like this. We used to popularly call under 5 wheezing, but now you can declassify that into older children, the real infancy, newborn. They are all dissimilar, because the wheezing in a newborn is not same as a wheezing of a bronchiolitis, which is different from wheezing in older children, and wheezing really of the type of asthma in an older child close to 5 years. Essentially, what you need to understand is, as soon as the slides are on, I wanted to tell you few of the basic things, and let me cut short my talk by 10-15 slides for want of time. And anyway, I will finish in another 20-25 minutes. I was supposed to present 45 minutes. Let me cut it down, and let me take more of question and answers, and we will end up in next half an hour. I will reorganize myself, and maybe we will have one more occasion in which I can present one wheezing in infancy, wheezing beyond infancy, as two separate topics. But right now, let us focus on wheezing in younger, and the youngest. Mind you, when you have a newborn, there may not be wheeze at all. And do you agree with me on that point? That is simply because the newborns may not produce sufficient amount of blast of air that can pass through the narrow airway passages to produce a sound. And the sound is either audible through the stethoscope or audible through directly audible. That sound may not hear. Yeah. So when you hear a sound in the newborn, it may not be wheeze at all. That is because, see, for example, when there is a blast of air and it has to produce the sound in the narrowest part of the newborn, and that is also small, you may not hear anything. So therefore, it goes without saying that sometimes when you hear a sound in the newborn, beware, it could be a stridor. It could be a larger airway obstruction. Am I clear to some of you? At least one of you can type in chat box.
Yes, sir.
Yes, okay. Yes. So just for my confirmation. So therefore, as the child grows older, the wheeze also matures. And you can have clear wheezing. And that's what happens in the rounds between 3 to 6 months. Some professor says, yeah, there is a wheeze. And the resident says, sir, kuch nahi sun raha hai, inko sun raha hai. Bada log bolte hai, to humko haan bolna padta hai. These things happen. And, as as it becomes very, very clear wheeze in a 3 or 4-year-old, and more so in a teenager or maybe an adult. And therefore, the wheeze also evolves as and when the bronchus becomes broader and broader and the obstruction becomes significant, and distal to the obstruction, there is sufficient volume of the air. The next thing I wanted to tell you, therefore, is confirm that it is a wheeze. This is important. So you must distinguish whether the noisy breathing I'm talking to is a wheeze, a stridor, and really a dry wheeze of asthma, or it's not rattling sound through bubbling through the secretions, or wheeze of pneumonia and wheeze of an asthma. And I'll again come back to you, wheeze of a pneumonia versus wheeze of an asthma. Both, I would say, rhonchi of asthma and wheeze of, rhonchi of asthma, rhonchi that you hear in pneumonia or lower respiratory infections versus wheeze of an asthma. In an asthma, there is air trapping and sufficient amount of air squeezes through the lungs or through the narrowed airways of bronchospasm. But in pneumonia and lower respiratory infection, there could be collapse. And many times, even in asthma, there is collapse. At that time, you don't hear a wheeze at all. Or there could be wheeze which was present becomes absent in a more severe asthma. Am I also clear on origins of wheeze, how to confirm a wheeze? And I cannot, a very nice question, what is the age cutoff in months for somebody to get a blast? I will say if it is a preterm, all the more, preterm versus a full-term newborn, in a preterm, all the more you don't expect any noise at all.
Raigad.
And therefore, my I appeal to my dear friends, please understand the logistics of the sound that I am trying to tell you. I am not able to give you a clear-cut age, but I wanted to tell you that the sound will be feeble and feeble younger they are. This much I can tell you, and I will leave it to your experience to judge as to whether you will be able to get anything, right? Okay. The next is localizing the wheeze. Sagar, are you there? Are you able to present the PPT? No, rhonchi in pneumonia, how they are produced. Okay, let me go to the questions. See, in pneumonia, you get both rhonchi as well as crepitations. You can use the word rals, rhonchi, or wheeze, but they mean the same. But what I meant was you can have a mix of sounds in pneumonia because of obstruction. Anyway, there is an obstruction. Distance to the obstruction, whether there is consolidation or no consolidation. That is the point. So in pneumonia, you can get mix of all sounds. Wheezes are also known. As much as in a consolidation, 30% can have wheeze and 30% can have crepitations, and bronchial breathing can be in 10 to 20%, something like this. You understand? It is not, but none of these signs are very, very specific. Only tachypnea is specific for pneumonia. Let me not deviate from wheeze to pneumonia because of a question, but all that I wanted to tell you is wheeze is part of other sounds that you hear in pneumonia. Now, what I am coming to is localization of a wheeze. It could be localized to a segment, a lobe, an area, or even half entire hemithorax, or more than that, or it could be generalized. When it is generalized, what we mean? What do you mean by generalized wheezing? See, I will ask a question to the audience. Let us say I hear more wheeze. The wheeze is there on both sides of the chest. There is more wheeze on the left side and there is less wheeze on the right side. Okay. Is this a generalized wheeze or a localized wheeze? Please type. I wanted this. This is a very, very important concept. Please. I think you understood the question, I suppose. What I meant was, there is wheeze on both sides, but one side has more wheeze than the other side. Yes, I can hear two types of chats. Some telling generalized, some telling localized. I think some are confused. Yes. I did not ask you the question, is it bilateral or not? The word is generalized. So generalized is not synonymous with bilateral. Okay, next slide. Wheeze at all, that we have confirmed. Next question, generalized or localized? This is where I am. Generalized means it should be bilateral, but not all bilateral are generalized. Because when I say heard more on one side than on the other side, it could be that one of the wheeze is more prominent and the conduction is more on one side better than the other. In that case, when you hear more wheeze on one side, less wheeze on the other side, please think of causes of localized wheeze. I think, is that okay for you? Let us say it could be a foreign body. This is where we miss. It is there on both sides. I think the word generalized means generalized and symmetrical. Bilateral means present on both sides. And I would say not localized means that is when, it is not localized means it is there on both the sides. But preferentiality or laterality would also mean that there is some localization. It is not that the wheeze is localized. The etiology could be localized. That is the point of understanding of generalized versus localized wheezing. And it is fairly understandable that in a syndrome like bronchiolitis or in a viral lower respiratory tract infection, there is no differential involvement, and therefore there will be a generalized wheeze. The next slide. Now the wheeze can be acute or persistent or recurrent, but in practice I have seen that persistent and recurrent cannot be separated. Many a times it is very difficult to separate a persistent wheeze from recurrent wheeze. That is because even in persistent wheezers, let us say there is an extrinsic lymph node obstruction or there is a anatomical abnormality. Can you go back to the previous slide, Sagar? Now what I meant was the persistent can present as recurrent when there is flare-ups because of infections or otherwise. And therefore, to separate a recurrent from persistent, really you have to sit and draw the diagram of how there is up and down of the wheezing. Then only you can come to know. Acute wheezing is fairly understood by most of you, that any wheeze that lasts for a week or two is acute, never beyond 1 month. Okay, the next one. Now again press another button. We can have wheeze because of either larger airway obstruction or a smaller airway obstruction. This is again too much larger airway obstruction is not wheeze at all, and that is stridor or noisy breathing, which I was trying to tell you. But what I wanted to tell you right now is that if you have a larger airway obstruction, often it is a monophonic wheeze. And if you have a smaller airway obstruction, which is variable obstruction, often you will have a polyphonic wheeze. This is very, very important for you to understand that, monophonic wheeze example is foreign body. Sometimes even in tracheomalacias, you will get, these types of what I would call monophonic wheeze. When you have a polyphonic wheeze, I will mimic it for all of you. One of you can type me in chat box whether you could hear a polyphonic wheeze, and this is how the wheeze is heard. Could you hear? One of you, please. One of you enough, because I wanted to just check. Yes, sir. Okay. Sorry to trouble you, sir. Now, the issue all that I wanted to just check is whether they're able to hear a polyphonic wheeze, which I had produced here. Fair enough. Now all that we have understood is that how do you get small airway obstruction, and there can be differential involvement, and therefore you can have a polyphonic wheeze. But tell me, in asthma, particularly, it is multiple squeezings at various levels, and variability is the characteristic feature. The next slide. No, bronchiolitis cannot be monophonic. That is because the smallest airways are involved, but that does not mean the proximal airways are spared. It is a diffuse viral disease predominantly involving the bronchioles. Now I'll come to the next concept. I think I'll spend only Hemant Bhaiya 2 minutes on this slide. I think this is the most important point. After that, the question asked by Pramod Bhaiya will become very clear. Now, wheezing very early, if it happens, it depends on the airway characteristics, and larger airway will produce more a stridor than a wheeze. All of you agree on this point? The smaller the airway, it will produce more wheeze, while in between larger and small airway will produce more cough. Of course, largest airways will produce more cough. I think cough will be more in the larger airway, more closer to the larynx, will decrease in the medium, Of course, it will be predominant. When you go to the smallest airways, the cough will reduce in intensity. Do you agree? That is first point. The second point which I wanted to tell you is, if you have a smaller airway obstruction, wheeze, smallest airway obstruction, wheeze is more than the cough. That's why in bronchiolitis you get a wheeze but not a cough. Am I clear? I think at least 1 point. Fine. Now, fine, Ramakant sir, for that update. Now, if I go for recurrent wheeze, I'm not talking of first time wheeze. This is when you will have variable obstruction, and a commonest example is inflammation or bronchospasm of asthma. This is where you have medium and small airways involved. So therefore, somebody is asking me to repeat the same. Okay, beta, I'll start from this end. You have two types of obstructions: fixed obstruction and variable obstruction. When I say fixed obstruction, it means that it doesn't vary. Variable obstruction means the obstruction or the amount of resistance, impedance, the flow becomes variable. There won't, see, for example, if you blow the air, it will come fast at times, it comes slow at times, again it comes fast and slow. But it will be uniformly slow or uniformly fast, but it will be obstructed in fixed. These words are not anatomical. The word fixable, fixed and variable are functional, but not anatomical. Am I also clear? You can take it as volume of air, pressure of air, blast of air, whatever. That is what is fixed, but not fixed obstruction as far as anatomy of the airways is concerned. Please don't read this word. I would say physiologically fixed obstruction, physiologically variable obstruction. Am I clear? If you have understood physiologically variable obstruction, you have understood asthma completely. Take it from me, because most often this part, variable outflow obstructive disease as asthma of medium and small airways, is understood for you, and therefore younger they are, less likely it is asthma. Are you also getting this point to you? And therefore, younger they are, you are likely to hear more and more infections and other causes. And 278. Okay, so therefore you will have some kind of issues related to concept of obstruction. Now, can I go to the next slide? One of you say yes. Because these 5 slides is what is the crux of the matter. Rest all is mechanical. Now, next slide, Sagar. Yeah, these 2 slides are again important to me. Next couple of slides. If you take risk of airway obstruction, again I'm coming to fix the airflow obstruction examples. Prematurity, low birth weight, rapid gain in weight gain in infancy, they will limit the airway, and therefore by virtue of squeezing they become fixed airflow obstruction. Is that okay for you? You go to the next slide, you will understand. Next slide. And therefore in these cases, if these children gets asthma, what I meant was, can you go to the previous slide, please? Sorry. This one. If these children with pre-existing fixed airway obstruction becomes asthmatic, they will have more PICU admissions. They are at more risk of COPD as adults. They will have more airway remodeling. It is difficult to reduce medications in asthma. They don't achieve control very well. Their lung functions may not return to normal. It may be difficult to wean off the drugs from them if they develop additional inflammation. Low birth weights, prematurity, rapid gain in immunity. Now, quickly you will understand why bronchiolitis is more common in prematures and low birth weights. Did you understand the concept? Can you type yes? One of you type yes, because that's exactly why you get uh, more bronchiolitis in these children because they have already an obstruction. And when you have an infection, it becomes very easy. The next slide, please. Next slide. This is again physiology, which is important. Now, if you go for um, the variable airflow obstruction, it is often because of poor compliance. These are the children who have past hospitalization. These are typical chronic airway inflammatory prototypes. Often these are the children who will have overuse of SABA because SABA just relieves them. And SABA may not relieve those who are having fixed airflow obstruction. Am I clear? But if you have a variable obstruction, when you take bronchodilator, there is good response. And therefore, can you understand that asthma is defined by response to bronchodilator and steroids? Now, one of you type yes for me, I'll be very happy. Now, did you understand the definition of asthma as a disease of wheeze? This is very, very important. It's not a disease of wheeze, it is a disease of obstruction. Obstruction is measured by spirometry. Obstruction is understood by wheeze, and variable obstruction is understood by the physiology, and recurrent variable outflow obstruction is the hallmark of asthma. And this is characteristically absent younger the age. Now, all of you close your eyes for a while and tell me whether can you recollect the types of wheeze that you get from newborn, post newborn, 3 months, 6 months, 1 year, 2 years, 3 years, 4 years, and finally you diagnose asthma. Did you understand how an under 5 wheeze will become clearer and clearer as you move towards asthma? Yes, for all of you. I don't know whether I've hypnotized you, but did you understand the concept? Please, one of you, because this is very important to me. Rest is all there in the Google and books. One of you type yes, no, please. Only one. One yes is enough for me. That this concept is clear. So increased age is more variable. Excellent point. I think now we have understood what is the origins of a wheeze, what is origins of asthma, and how can you, what are the risk factors for obstruction of airways. Now the next slide. Next slide is very easy for you. In these children, you have to emphasize on good control, and you can actually taper off the medications in them and outgrow the wheeze or asthma, the so-called within inverted commas outgrowing. This is the prototype. Next slide, Sagar. Now, the slides are pretty simple. I don't know whether I should continue or shall I continue for another 15 minutes? All of you say yes, then I will go ahead, because I wasted a lot of time. Now I will rush through the slides.
No,
These
sir,
are,
sorry
shall I continue?
Please continue. Please continue.
Okay, Pa. Kapil, thank you so much. Now, this is when I am coming to the point. A given child with cough and wheeze, is it asthma? And if yes or no, in either case, how should I treat a recurrent wheeze? I think if you have understood physiology and anatomy to me, my dear friends, it is not difficult to treat a wheeze. The next one. Now, the entire question on recurrent, when the wheeze happens more than once, is the wheeze frequent or the wheeze infrequent? Are you getting the point? Because if it is infrequent and occasional, it could be by default acute. It could be by default first time or just second time, not more than 3 times. There is a reason to wheeze, for example, an infection, and there is no reason to recur. I think this is beautifully understood by all of you, what you mean by less frequent wheezers versus frequent wheezers who know they have a reason to frequently wheeze, either because of anatomical factors like age, prematurity, low birth weight, so on, so forth, or they will have environmental reasons which are not solved and therefore they frequently wheeze. For example, smoking parents or an outdoor pollution, or They will have genetic risk factors like atopy, family history, um, or I would say epigenetic factors that make them to wheeze, or there could be an etiology of whole lot of biological and immunological inflammation that is the reason for frequent wheezers. Now, is it that a child can be categorized into less frequent wheezers and more frequent wheezers? No, this is a spectrum. And this spectrum is the one which is causing confusion to all of us, my dear friends. You may have one time wheeze, two time wheeze, three time wheeze, four time wheeze, five time wheeze, six time wheeze, but it is not a mathematics, my dear friends. Three wheezes in 1 year, five wheezes in the next year, six wheezes in the next year. This is what you see in the practice. Or it could be one wheeze now, 2 years, nothing. Suddenly in third year, four wheezes. Did you understand? So therefore, you have heterogeneity of wheezing. And that makes it difficult for the pediatricians to diagnose asthma because he has to relate the reason for frequent wheezing. Now, I think, did I make this concept clear? This is when a pediatrician has to clinically get convinced that, look here, I am having frequent wheezing and the reason for it is asthma. Now, next slide. Now, first wheeze is called bronchiolitis, whether you like it or not. It often happen before 2 years of age. And now you all understand, I have explained you basics of wheezing. Why below 2 years you get bronchiolitis? Very understandable. Simple lower respiratory tract infection in an anatomically small airways as small as caliber of 2 years and below is bronchiolitis. Can you make them larger airways? Answer is no. The epidemiology of the virus is such that they affect the distal airways than the proximal airways. That is the characteristic feature of respiratory syncytial virus. Is bronchiolitis a disease or a syndrome? Bronchiolitis is not a disease. It is a syndrome. Because rhinoviral bronchiolitis is not same as respiratory syncytial viral bronchiolitis, and RSV is not same as parainfluenza bronchiolitis. Any virus can cause bronchiolitis in that age group. Please understand my point. Therefore, you can have separate types of wheezers and different prognostic factors and different clinical profiles, variable severity and variable presentation in bronchiolitis. Now tell me, does a rhinoviral bronchiolitis behave same as respiratory syncytial viral bronchiolitis, which is same as bronchiolitis due to some other virus? No. Therefore, please don't ask, sir, what is the treatment I should give for bronchiolitis? That's a very wrong question. One shoe doesn't fit all. My dear friends, now you know why there is controversy in bronchiolitis management. For example, the viral infection in Raigad, nobody has done any research and many may not know what it is. And of late, we got another virus like COVID. None of us knew. We have the pandemic is over. There could be emerging viruses which come in future. So therefore, my dear friends, bronchiolitis is a syndrome of infection. And more than infection, it is a syndrome of obstruction. Because by default, it is 2 years. And the treatment for obstruction is symptomatic. Whatever narrow passage you have got, you have to push the air through that. And through the air, you have to supplement oxygen through that. And you have to support the child by IV fluids. Now, answer to my question. In mild bronchiolitis, does hypertonic saline works? Does steroid works? Does antibiotics work? The answer is no. And we do that. We do give them. And that is where we go wrong. Can a bronchiolitis recur? It can recur till 2 years of age. But you should have a reason for recurrence. Did you understand? How many seasons a child can pass through by 2 years? See, One, of course, nowadays there are no seasons. Suppose you take spring, or you can take rainy season, winter, whatever. There can be at the most two seasons or 3 seasons before 2 years of age. All of you agree? So therefore, now tell me, did you understand? Uh, did you understand that more than 3 episodes of wheezing qualifies for asthma, because this is wheezing apart from colds? Now, did you understand? Please type yes, one of you, please. I think now, did you understand how there is a non-seasonal reason for wheezing, and which is not defined by anatomical or functional characteristics of the child, but for the inflammation that the child is wheezing, and therefore there is asthma. Now, can you tell me the answer again? Can the youngest kid, let's say 2-month kid, can it get asthma? Please type in the chat box. Can you have asthma in a 2-month-old child? Somebody was asking, what is the youngest age you have seen, sir? Can anyone boldly tell me, a 2-month-old kid, can it get asthma? Yes or no? No, isn't it? Can a 6-month-old child get asthma? Yes, no? Probably illness. And is it right that younger they are, if you diagnose asthma, more likely that you are wrong, because the cause of wheezing is more likely to be non-asthmatic than asthmatic? This is exactly how I have taken you through that story of wheezing into definition of asthma. Now the next slide. Please tell me when you get bored, I'll stop and I'll take up questions. Now, wheezing in older children, why do the colds in the chest recur? Now I have come to this typical preschool wheezing, which you see those kids who come frequently to your clinic. See, there could be an atopy. And therefore the child may wheeze at least 2, 3, or 4 times. But does it mean that it should wheeze for life? Not necessary. It can wheeze 3, 4 times and then may not wheeze at all. Or it could wheeze 16 times in 3 years. And the whole of the next of the life, it may not wheeze at all. That means to say, the genetic determinants, the environmental insults, the product of both is not sufficient enough for the wheeze to frequently recur again and again. I think I made this concept also very clear. Now tell me the management of wheeze in older children. Just put your hands on your heart and ask yourself, is it more likely to be asthma? Yes, no. If it is not likely to be asthma, manage the episode. If it is more likely to be asthma, then keep a watch. Am I clear how to handle wheezing in older children? Treat them episode by episode. When they recur more frequently, analyze them. Next slide. Next slide will explain you everything. This is a slide which I've actually copyrighted by me. This is the slide with which efforts I have put to make this slide. Please spend 2 minutes on this. When you have increasing age versus risk of asthma, as the age advances, the risk of asthma goes on increasing. Do you all agree on this point? And they could pass through a phase of recurrent wheeze, not an asthma, or recurrent wheeze, not yet an asthma, or I would say first time asthma. Good. Now this slide is understandable to all of you. There will be first time wheeze, it keeps on recurring, and now you may have asthma, but it is not, I have not written any age down. You can write your own age, one by month or by years, whatever, and then you can define the asthma in that particular child. Next slide. Yeah. Now, can I predict asthma in a wheezing child? Lot of trial studies have been done to identify asthma in a wheezer. And can I go to the next slide? We have seen them, and these are the studies. The famous was a Tucson study where they followed up the wheezers and they found that the wheezers can be transient. And why the wheezers are transient? The airways outgrow, immunology evolves, the viral infections decrease with the time, and the child will become better adult, and therefore wheeze decrease, and these are called transient wheezers. I think in your office practice you must have seen some mothers coming to you, sir, in first year 6 times, second year 4 times, third year 2 times, fourth year they disappear, and you might have thought they have gone to neighboring pediatrician Pramod, but later you discover that for the second child the mother walks in again, sir, again paratala. That means again it came back. Do you agree? And therefore, my dear friend, this is a very, very important. These are called transient wheezers. And you can also therefore have some kind of non-atopic but little persistent wheezers who will again outgrow the wheezing. And some will actually have late onset wheezing and they will wheeze forever. Is it possible? Answer is possible. But when it comes to your clinic, can you categorize them? Answer is no. It is not possible for us to categorize them into transient wheezers, persistent wheezers. And you can start with predicting them. They can go either way. What you thought transient may persist. What you thought may persist may become transient. Did you understand my point? So, my dear friends, as you are in the clinic, you are at the point of time, and this classification is over a period of time. This is excellent epidemiological classification from Tucson study, but the point which I wanted to tell is not useful in the clinic. There are many other studies. I'm not going to quote them. ISKCON study. Later on, they started looking at risk factors for wheezing than the fate of wheezing. Did you understand? We are not interested in fate of wheezing because whether it wheezes or not, only time will tell us. Now, I am wanted to know whether there is a risk of next wheeze. Did you understand the risk approach now? Please type yes. Do you like a risk approach or the number approach? You want to tell the mother the risk next, or you wanted to know the risk of wheezing next, or you want to know whether you want to go for this phenotypic approach of classification. And therefore, can I go to the next slide? Next slide, please. Therefore, we went to the risk approach. But in the meanwhile, while these transient, persistent, etc. wheezers approach was used, European people started classifying them as episodic and multi-trigger wheezers because they wanted to identify some type where they can give Montelukast or steroids, which are nothing but those who wheeze for more than one trigger and those who wheeze for only viruses. Those who wheeze for only viruses are called episodic wheezer, and those who wheeze for many other things are called multi-trigger wheezers. But mind you, this classification is useless because to start with, they may wheeze for viruses. Later, they may wheeze for other things. How can a 6-month-old child wheeze for, will it wheeze for a dust or will it wheeze for a virus? It will wheeze for a virus. 2-year-old child, will it wheeze for a virus or will it wheeze for a dust? It will wheeze for a virus. 3-year-old child, will it wheeze for a dust or virus? 50-50. 5-year-old child, will it wheeze for a virus or for a dust? It will wheeze for a dust. Therefore, my dear friends, even this classification also was not useful, although it is very popular. See, please don't listen to this classification also. I think I have made you to unlearn what you have learned already, and these two are useless for you, but only for research purposes, for all practical purposes. Now, can I go for the next slide? Next slide, please. Yes. Therefore, we are going for what is called as risk-based probability approach. And that is what Gina has taken for prediction of wheeze, whether it will be an asthma or not an asthma. Next slide. This is the slide in Gina. After finishing my lecture, please download from the internet and read everything here. As you move to the right of your screen, the risk of asthma is more and more. As you come to the left of the screen, the risk of asthma is very less. That means if you have cough and colds short, 2-3 days, if you have a number of episodes less than 3 or 4, and if you have no family risk factors, then you are on the left side of the graph. While if you have family risk factors, genetic risk factors, If you have frequent episodes, in between episodes, they are not fine, then you are on the right side of the screen. Did you understand? So this is pretty simple approach. So therefore, my dear friends, a child passes through from left to right if it is asthmatic. If it is not asthmatic, child will remain in the left column. Did you also understand? Fine. Go next. Risk-based approach will take some reason for recurrent wheeze, and the reason for recurrent wheeze is not inflammation alone, my dear friends. It should be chronic, persistent, progressive, cascading inflammation. That means I will say first time 500 milligram of inflammation, next time 1000 milligram of inflammation, next time it is not 1500, my dear friends, it is 2000 because of cascading effect of inflammation. Next time it is 4000, next time it is 8000 gram of inflammation. I'm sorry for using grams for you to understand. Next time it is 16,000. Next time it is 64,000. Did you understand how with each infection, an insult or a trigger, there is cascading effect of inflammation, and therefore the child ends up with asthma and demands steroids. That's exact. And the reason for this, cascading effect or progressive increase in the inflammation as and when the insults happen is because of the genetic susceptibility. And therefore, did you also understand why a previous child, which was thought to be an episodic wheezer, becomes a multi-trigger wheezer later in life? You have understood. You have also understood how asthma evolves as a whole sort of cascade of inflammations involving the airways. And I think now you have all understood how an at-risk child evolves into an asthma in a wheeze. Next one. I'll go a little rapidly for want of time. Next one, please. Now there, and if you see young wheezers, you will have 5 categories of wheezing. And all of us understand normal child can wheeze. Definitely yes, because its airways are smaller than that of an adult. The second category of wheezing is serious illnesses like TB, cystic fibrosis. These are, how can I diagnose them? You don't look at wheezing. You look at the child. Child will not thrive. Child will not grow because of the disease, not because of wheezing. The next one, the child is otherwise fine, not like serious illnesses. They fit into asthma syndromes. This is where a lot of confusion is there for all of you. There are 2 categories in asthma syndromes. You have wheezing looking like asthma, but not asthma. You have in asthma syndrome, you have wheezes looking like asthma, but yes for asthma. Did you understand? So you have yes or no for asthma, but the presentation looks like an asthma syndrome. Did you understand? Of course, you can have over anxious first time parents who ask you, haunt you with questions like, my child, does it have asthma? Yes, no, doctor, tell me all this. Forget all of them. That you can handle them with counseling. The next one. Next slide. How do I say a child is normal? This is most important for you. You must be bold enough to tell them, yes, you don't have asthma. But here you have to go for diagnosis of exclusion, which can happen by absence of risk factors, absence of reason for recurrence, or decrease in the severity and frequency of wheezing with age. So therefore, you can diagnose either by the pointers at the point of time or evaluation over a period of time. And you will tell them, don't worry, it's a normal child. Is that fine for all of you? Most often, these children don't have atypical features like having noise since newborn period. They don't have reasons like getting admitted. They don't have reasons like, you understand the point. They're not like that sick children. They're okay. Whenever they let them go to any pediatrician, they will succeed in treating them. They'll write some syrups, useful or useless. They somehow recover. Next one. Next slide. Now, how do I know normal children? They have brief episodes. They are normal in the interval period. Next slide. You can quickly go through the slides. These are the children on the left box of the GINA. Is it clear? Less episodes, brief episodes, and in between they are normal. The next slide. The previous one, sorry. Previous slide. Next one. Next slide, please. Yeah, these are the children who outgrow the wheezing as they grow older. Correct? No, normal children with wheezing. Okay. Transient wheezers. Next one. These are the children who will, have a recurrent wheeze but abnormal child. Please understand, they look abnormal, they behave abnormal, their growth pattern is abnormal. They may have clubbing, they may have wet cough, they may have systemic features, they may have recurrent fevers. Did you understand? Some nose, some ear problems. All these are, you have to sort them out when you are examining. Don't say, sir, wheezing hai, theek ho jayega. By 5 years, they will become better. You must pick them up because you have to evaluate the cause of wheezing. These are sometimes called by few people as atypical wheezing. Okay, the next one. Next slide. They have serious disease, you need to investigate or refer them. So far, you have understood normal. Next slide, no problem. Aram se. Next slide. So therefore, you have understood recurrent wheezing. Around more than 80-90% of them are normal, or in very small number of them, they can be as a part of the disease like TB, cystic fibrosis, etc. I'm just given two examples. It could be any other. For example, a left to right shunt with wheeze. Next slide. If you take out these two category, in between, you feel that it is asthma. Somehow, sir, mere ko asthma lagta hai. These are asthma syndromes. They may or may not be asthma. The left one can be asthma, right one may not be asthma. By look or by examination, you cannot make out which of the horoscope is bad. Did you understand? The next slide. In them, you have typical and atypical wheezing. Typical means there is no, they are generally fine, happy wheezers. Atypical means they will have some atypical features. There will be some clues for the disease. Sometimes they look like asthma, but they're not asthma. See, everything looks fine, happy wheezer, but first time you auscultated, there was an infection. I'll give an example of a foreign body. Sir, mere ko lateralization nahi laga. Both left and right were same, sir. But when I auscultated second time with another pediatrician, I found there was localization. Are we not cheated in our practices? So sometimes they are picked up at times atypical features. So for example, initially clubbing may not be there. Clubbing may evolve. And therefore, my dear friends, these are the ones who are called as atypical wheezers. Look like asthma, but may not be asthma. Next one. Next slide. Yeah. Therefore, in those which look like asthma, how to tell yes or no for asthma? That's all. That will finish my talk. Next one. When it is not an asthma, see, I mean to say, I am not talking of like you say, very atypical wheezers here. Typically, they are wheezing. If they are too young, it's not asthma. Next. Next slide. If they are too sick, it is not asthma. Next slide. Next slide. If the episodes are febrile, it may not be asthma. Did you understand? Next one. If they're not responding to bronchodilators, it may not be asthma. Or if they're not responding to steroids, it may not be asthma. Next slide. Next slide, please. So therefore, did you understand that all that wheezes is not asthma? It's very important, my dear friends. So therefore, anything that wheezes may not be an asthma. Now you know also what is an asthma. I'll come to that. Next slide. Next slide will summarize what has been discussed so far, we have learned that all that wheezes is not asthma. Then when it is asthma? Next slide. Next slide, please. Go ahead. Yeah. Asthma is likely when you have recurrent symptoms, afebrile. Recurrent symptoms, I mean to say more than 3, 4 or more. If they're afebrile, if they're triggered. Why triggered? Because there is a pre-existing inflammation. Thoda sa one small spark will put the fire. If they are in episodes, if they're well between the episodes, and if there is a family history, and if there is relief by bronchodilator or steroids. Now, are you clear when a wheeze is likely to be asthma? Next one. Next slide. Next slide. I'm linking you to the same GINA slides. Now look at, if you have symptoms, prolonged symptoms, if you have frequent episodes, in between if the child is not normal, and if there is atopy or family history of asthma, you are more likely to diagnose a recurrent wheeze as asthma. Now, did you understand this slide? This is the most important slide in GINA. Everybody reads by hearts, but they don't understand. This is most important part. Next one. Next slide. Now you have, now let us say, do the children walk in with textbook description? Answer is no. I cannot just convince you by my vocabulary that yes, a child will be an asthmatic or no asthmatic. It is not necessary in practice. Sometimes you may have a risk factor, but the child may not wheeze at all. Sometimes you may not have risk factor, child goes on wheezing frequently. Do you agree? Have you seen all these kinds of excellent question by when to use ICS? I'm coming to the exact point. Now, therefore, if it is asthma, you are going to use ICS. Otherwise, you are not going to use ICS. And that is the answer. So, therefore, is it asthma? Next slide. I'm almost finishing my talk. You are already 11:15. I'm sorry. When it is obvious. Now, tell me when it is obvious. When you are on the right side of the GINA slide. When it is too obvious. When you say it is 100%, sir. 6 episodes ho gaya, family history is there, atopy is there, one more sibling is also suffered, I have documented the wheeze. Did you understand? It is too obvious. You don't have to ask any Tom, Dick and Harry for this. It is mothers also will tell asthma. Next slide. This is the slide of the GINA. You can diagnose in young if there is recurrent wheezing triggered either because of excessive laughing, exposure to tobacco or smoking, if there is family history, and if after a therapeutic trial they also show improvement and on stopping, that symptoms worsen. Yes, you should give trial of ICS when there is doubt. That Dr. Jayant, you got it right. Next slide. Next slide, please. Now, can you identify now from my talk what is not an asthma at all? Yes, by symptoms. Next slide. Next slide. Next slide, please. No. I think you went a little ahead. Okay. Maybe you are correct. Uh, yeah. This is what. Now you know what is not an asthma by way of symptoms, frequency, age, or by atypical features. Is it possible for you to at least tell what is not an asthma? Yes, possible. You may not be able to tell asthma, yes. But no for asthma can easily be told, isn't it? Excluding is easy. In fact, even the research studies have shown asthma predictive index is more an asthma unpredictive index than a predictive index. That is because negative predictive value is very high. Next slide. If you are undecided, you should go for a trial of ICS. That is when you ask for third umpire, that is trial of ICS. What happens after a trial of ICS? You give 100 microgram of budesonide twice daily for 3 months, no tapering, abrupt stopping. They respond. They take time to respond. Some will respond by 3 weeks, 2 weeks, some takes up to 6 weeks. If they all they respond by 6 weeks. You should not stop there. You should continue up to 3 months. By 6 weeks also, if they're not at all responding, they're unlikely to respond. But you can continue, but you can start investigating by 6 weeks itself. They may not respond. Continue the treatment while you evaluate. If they respond, stop the treatment. Again, the symptoms recur and you reintroduce ICS, they will become better. Now, next slide. Now you understood. Next slide, please. Now you understood. If there is no response to ICS, what does that mean? Revise your diagnosis. Did you understand? Next slide. If there is a response, probably you are dealing with asthma. So now you understood when to call a wheeze and asthma. Now there are two situations. One, straightforward diagnosis of asthma. Second, after a trial of ICS, you confirm asthma. Now, these are the indications for low dose inhalation corticosteroids, my dear friends. The third indication, apart from these two, is when the wheeze is too frequent. Too frequent. Every month he is wheezing, but I am not able to prove asthma. Then also you can give inhalation corticosteroids. So that means too frequent and episodic wheezer. Understand, multi-trigger wheezers, if they start wheezing frequently, you know, you will have the all the things that I have told you. They'll respond to inhalation corticosteroids. At times, you know, some wheeze frequently, but they demand steroids, but they don't qualify for asthma, but you may have to give short course of steroids. Did you understand? But for them, generally, if it is too obvious in asthma, number one. Number two, if after trial of ICS I have confirmed asthma. Now, did you understand when to give inhalation corticosteroids in a wheezer? If you say yes, I will proceed because I am done with wheezing, because this is the most important concept. Because if you don't understand when to start daily low dose inhalation corticosteroids, my talk would be a failure. Is this understood for all of you? Please, one of you type yes. Okay, at least one has understood. Thank you, Pa. At least I could make out that you have understood when to start inhalation corticosteroids. Next slide, please. I'm coming to the almost end of my talk. Now, very rarely you can confirm by pulmonary function tests as far as the diagnosis of wheezing is considered. So often the diagnosis becomes clinical because when you test at that point of time, PFT. It is not over a period of time. You have to do sequential PFTs, which is very difficult. You understand? So next slide. So therefore, the diagnosis is clinical. Will a child gets asthma is same as will any one of them become prime minister. This is more an unpredictive index than a predictive index. Did you understand my point? It feels as though, yeah, this will going to become asthma, but majority of the times under 5 and younger wheezers don't turn out to be asthmatic. So therefore, please think twice before you declare them as asthma. Is that clear to you? Okay. Do you need always an evidence? Next slide. Next slide. Do you always need an evidence? It is so obvious at times. As a pediatrician, you are convinced. And now, did you understand? With or without investigations, you can diagnose an asthma. It will be very obvious a clinical scenario. Of course, the mother will demand for ED investigations and final proof. But the point which I wanted to tell is that it is not necessary that you need to make a diagnosis at that point of time. Next one. Next slide. So I think I have summarized for you. I'm coming to this almost the summary slide of today. The frequent wheezers in young can have normal recurrence. It can be as a part of the disease. All that wheezes is not an asthma. When a wheeze can be called an asthma, how to predict asthma in a wheezer, and how and why an asthma do not require, and how does investigations do not benefit in asthma. I think I made all these points clear to you. Next slide. I'm coming to the last questions are also there on this. Only 3 slides are there. Please bear with me. I'm sorry for the delay. Treatment of under 5 wheezing. Whether it is asthma or no asthma, let's not bother. If it is asthma, you have to give daily low dose inhalation corticosteroids. Now, people have tried these drugs to see if they can prevent disease progression of a wheeze into asthma. They have tried antihistamines. They have intermittently tried ICS. They have tried continuously ICS. Mind you, you cannot stop a child by starting steroids that it will evolve into an asthma. It will anyway evolve into an asthma. At the most, you can suppress the inflammation. You can't change genetics. Did you understand? If not now, when you start steroids, when you expose the child to the same dust, same genetics is there. If not at 3 years, he may develop asthma at 8 years. If he were to develop, is that point also clear to you? You cannot halt or stop, or by giving you cannot make the child better. This is the point. Please understand, the limitation for us is genetics. Therefore, again I'm coming back to the point, after all, the treatment is symptomatic. If nose is involved, give antihistamines. If chest is involved, give SABA. If you think inflammation is the cause of giving SABA, then you give ICS. If you think that the child is too sick to get admitted and is in acute flare-up, give oral steroids. If you think, no, this is unlikely asthma, but an infection, give antibiotics. Is this fine for all of you? I think it is pretty simple. There should not be any confusion for you for, treatment of under 5 wheezing or wheezing in young. Next one. Next slide. Yes, there is always yes for bronchodilators because they are safe. You use them when you have infrequent episodes, which I think I have made you understand. If there are no interval symptoms, probably viral. But don't tell me viral episodes you can give bronchodilators. No, it is you can give bronchodilators, but it is not a rule that they should respond to bronchodilators. And there are no risk factors. In those cases, only bronchodilators are enough. This is in younger, but not in older children. When they become old adolescents, you must give ICS along with uh, um, uh, ICS along with bronchodilator. Okay. Next slide. Somebody asked this question: when to give low dose ICS? Asthma likely, and there are more than 3 episodes per year. That means 4 or more episodes. Unlikely but frequent episodes are there. Or if after a trial of ICS, it is proved to be an asthma, you can start low dose ICS. Is this also clear to you? Now, antibiotic. Next slide. When to give antibiotics in a wheeze? See, my dear friends, I am discussing not antibiotics for all causes of wheeze. I am discussing antibiotics for recurrent wheezing. Did you understand my point? So, can you give antibiotics? The bold answer is no. If the febrile episodes are more than wheeze, I don't know whether you understood. And if suppose if the sputum is wet, or I would say wet cough is there, in such situations you may consider antibiotics. And if you have a situation like persistent asthma, very severe asthma, stage 4 and 5, and a wet cough, something like going similar to COPD, you may consider macrolides. Here azithromycin is given for 3 months, not your 3 days and 5 days. My dear friends, I'm not getting into controversial areas of giving antibiotics for long time. Okay, how duration of low dose ICS? Somebody is asking. It is as long as inflammation exists. You should not give less than 3 months. You should not stop just after 3 months. It is not trial of ICS, my dear friends. There's for stopping or tapering, there should not be any wheezing episodes in the past 6 months. That means you will start first 3 months, you will stabilize the child will be titrated, and next 6 months you continue. Let us say a child responds, that means 3 plus 6 months, 9 months it became. Did you understand? I don't know whether you understood. First 2 or 3 months will go in evolution of control of the disease. Fine. He settled with low dose ICS. Fine. You to stop an ICS, you need at least no symptoms in the past 6 months. That means 3 plus 6 months, 9 months is over. And can you abruptly stop? Answer is no, you have to taper. You have to reduce 50% every 3 months. Let us say he's on low dose, he will be tapered off in 3 months itself. Suppose he is on moderate dose, then you may require 3 plus 3 months to reduce. That means generally the treatment will be not less than a year. Is it clear to all of you? Because again, this question is being frequently asked. Please type yes in the chat box. How long to treat? I'm telling at least it will be 9 months to 1 year. You cannot think of shorter durations. Okay. I'm talking of low dose ICS on long-term therapy, not as a trial of treatment. Next slide. Next slide, please. So, do the steroids or Montelukast do any magic in wheezers? Answer is no. So therefore, my dear friend, just say no to them. They don't do anything. When steroids can't do anything, what Montelukast can do in under 5 weeks. So people are having some kind of itching to give Montelukast. Please don't do that. It's of no use. Sometimes when you are prescribed Montelukast plus levocetirizine, it is the levocetirizine that has worked. The next one, next slide. Somebody is asking what is the role of nebulization. Role of nebulization is same as role of bronchodilators, my dear friends. Now, this is the most important slide, and that is why I have explained to you in the first slide. Now, can you recollect the physiology for me? Fixed and variable airflow obstruction. Give bronchodilator. Airway inflammation. Give steroids. Airway infection and impaired host responses, give antibiotics. Please take a screenshot of this slide. This is very important for you. Is that clear to most of you? If you have obstructive features, let us say the first one is bronchodilator. Second one, inflammation, steroids. Third one, infection, give antibiotics. My dear friends, is it that a child fits into box one, left box, but not middle box? Answer is no. You may have a child who has more of airflow obstruction than airway inflammation. There can be mix. Therefore, you may need both bronchodilator and steroids. So therefore, I will say bronchodilator plus or minus inhalation corticosteroids plus or minus antibiotics. This is summary of treatment of lower respiratory wheezing. Next one. Oral bronchodilator has same role as inhalation. Inhalation is superior. Now, in conclusion, you have normal recurrence by default of physiology, anatomy, immunology, and airway growth. If it is a part of the disease, if the wheeze is because of a disease, the manifestations of the disease are more prominent than the manifestations of the wheeze. You have to identify these sick children. If you plot them on the growth chart, they will fail to thrive. They may have multi-system features, or they may have localizations. All that wheezes is not an asthma. How do you know? Sometimes you may feel generalized wheeze, but when you re-examine next time, you may find a localized wheeze. Sometimes foreign body history is not taken. Did you understand? It may not be wheeze at all. Sometimes it is a noisy breathing that is mistaken for wheeze, and therefore all that wheezes is not an asthma. And sometimes all that wheezes may be febrile wheezes. Over years, they may not wheeze at all. And therefore, it could be that they outgrow wheezing. So therefore, my dear friends, all that wheezes look like asthma may not be an asthma. And you also know when a wheeze can be an asthma. That is when you have risk factors, mainly risk factors. You must go for probability risk approach, not phenotypic approach for diagnosis of asthma. And asthma does not require investigations, my dear friends, because you have evolved into diagnosis uh, by your analogy, and therefore you don't require much investigation. But you would require investigations to rule out other diseases. In a sick child, do you require investigation? Answer is yes. But in a healthy, happy wheezer, do you need investigation? Answer is no. how, when, and why a wheeze is an asthma. I think you have understood. And I'm coming to the last slide of mine. My dear friends, last slide is most important. And I don't know how to thank you, because now also I see 86 participants after half an hour of gap. I'm really indebted to you. I'll quickly buy a new laptop and see that all these, or I will repair the laptop and see that all these problems are sorted out. I never knew, I never failed in Zoom, but it's first time I had that an experience. And I'm greatly indebted to you for being so patient till the end. Let those who want to sleep, you can sleep, but those who want to ask questions, please ask questions. Sagar, for a while you sleep one half an hour late, pa, for all of our sake. If there are questions, I'm very
So
happy to
usually I
take.
sleep at 1 o'clock.
Then no
Don't
problem.
worry.
Don't worry, you can ask any question, and those of them who are interested will
So,
continue to be there. And in a Zoom, anybody can
so
sleep also. Aram say you can take a pillow and just listen to whatever little you can, and you can be at your physiology. I'm very thankful to you, but my apologies. I try to control the time and flow, but for want of these hitches, I couldn't. Now, Sagar, you can ask the questions and stop sharing the screen.
yeah, so those, it's a kind request to all of you. Please type your question in the chat box. So meanwhile, I will ask you, sir, one or two questions
Please,
which are there in chat box. Like
please.
somebody asked in beginning, because
I was
started with the
just answering
bronchiolitis.
as and
So
when I went. Correct, no?
correct. So in between, even I have answered somehow
Yeah, yeah.
some
Please
questions. So
continue to ask. Not
there is
an
one
issue.
question called, the treatment for bronchiolitis in, can you give it in 5 sentences, not more than 5 sentences?
Okay. I can tell you in 2 sentences. The things that work,
Okay, that's right.
things that work is only supportive care, no drugs. Water supportive care, oxygen and IV fluids. That's all. It is a self-limiting disease. More than 50% of the bronchiolitis is self-limiting. It is, I will tell you what is bronchiolitis. It is colds in the chest. Now tell me, cold in the nose, what are the drugs that are required? Is it antihistamine? If your answer is that cold and cough syrups is no, on the same lines, the bronchodilator is also no on the lower part of the chest. And I will explain to you, somebody was asking, sir, why no for bronchodilator in a bronchiolitis? Sir, why the bronchodilators don't work? That is because in younger children, the airways don't constrict. They tend to collapse. I don't know whether you got the point. It's like touch me not plant. Touch me not, you have touched now the plant. It flops. Like that, in bronchiolitis, the airways tends to collapse with obstruction, and there is significant obstruction. And when the point, as long as the obstruction is there, I'm showing my fingers. Obstruction is there, 1/4 diameter is reduced, you get wheeze. If further obstruction is there, it collapses. And there's ventilation perfusion mismatch, and that is severe bronchiolitis. Did you understand? So if there is a mild to moderate obstruction, the hypoxia will be there, but it will be correctable with oxygen. More and more ventilation perfusion mismatch happens, the child becomes more sick, and the child don't respond to bronchodilators. That's when we need HFNC, CPAP, ventilation, so on and so forth. The whether they respond to a bronchodilator or not depends on where is the bronchodilator situated in the airways. Bronchodilators are not there in the nose. Bronchodilators are not there in the larynx. Bronchodilators are there in the trachea onwards. Most of the bronchodilators are there in the smooth muscles, my dear friends. Smooth muscles. Did you understand? And smooth muscles are not that well developed in younger children. Number one. Number two, what is the definition of a bronchiole? The part of the respiratory tree when the smooth muscle stops. It is just after the alveoli, you get bronchioles. And after that, it is called as bronchi when there is smooth muscle. So anatomically, by definition, bronchioles are devoid of smooth muscles. That means they are deficient of beta 2 receptors. Now, but then, sir, sometimes why they work? That is because you have dilated the proximal airways. Some of your path up to the distal airways becomes easier. Therefore, now have I understood why some children with bronchiolitis respond to bronchodilator? If your virus is of the type that it involves the proximal airways, or if the inflammation is not just bronchioles but extending up to pan airway inflammation, or he is actually a candidate of asthma, this is the first episode of asthma, they will respond to bronchodilator, because asthma by definition should respond to bronchodilators, and I've explained you why also. What is the rule that 6-month-old child has an first episode of asthma? It will become diagnosed asthma at 3 years, but when at 6 months he was provisionally diagnosed as
Sorry
bronchiolitis.
to interrupt you, sir, but I told you only 5 sentences.
Okay,
You
okay. Sorry. I will
okay?
tell you. I will cut. You cut me, no
So
problem. You are the moderator, boss. You can
yes.
cut me.
So
No problem. Yeah, yeah.
another
I was
question is,
explaining the bronchiolitis and
I know,
bronchodilator.
I know,
Next one.
I know, I
Next
know.
one.
So
Yeah, yeah.
any epigenetic factor to suppress genetic, as you said, that asthma, some
Yeah.
kind of genetics in,
There
there is
was
a
some
genetics involvement.
rosy stories about asthma vaccine, and I think it will be a different confusing session. In
Yeah.
our advanced asthma course, we'll explain
So
them all these, what is epigenetics and how you can modify the genes. But I will tell you how you can worsen the gene by environmental smoke. There is
exactly, exactly,
demethylation and
exactly,
worsen. Whether we can
exactly.
reverse that or not is a matter of research.
So study says that maternal smoking or any inhalation, smoking inhalation, is it active or passive? That can change. So only, as rightly said, genetic epigenetic factor which can suppress the genetic. The another important thing is somebody has about, I think we are going into more of a bronchiolitis perspective. So um, so somebody has started. Okay. So when should we call? So this is my question for. I mean, I'm asking question
No problem.
for a general pediatric perspective, that suppose you have started the ICS. Okay. So you said give it for 3 months. So how long should they wait to have that response? As you said, 6 weeks.
Generally 6 weeks, not
Correct.
necessarily 6 weeks.
Not six.
No, but
So
that means if they don't respond by 6 weeks, start investigating, thinking that you will not respond by 12 weeks.
absolutely. So that should be the message. Very, very important to highlight
Don't
that.
stop at 6 weeks if they don't respond. You have to
Don't,
complete the trial for 12 weeks. But
exactly.
by 6 weeks, if they don't
Start
respond,
thinking about
don't
something.
start evaluating. You may have to do CT scan, you may have to do cystic fibrosis study, sweat chloride test, or look for a foreign body. You have forgotten history, you re-ask the history. You can do all these things, but not stop ICS. Is
Yeah.
that message okay, Sagar?
Yes. So another important thing is, as a as a bronchoscopist, what I see in this smaller age of group, which they come to me when they are referred to me. So when
Hmm.
I do bronchoscopy, the commonest thing what I see is malicias. So airway
Malaysians.
malicias are very, very common in infancy, less than 1 year. Second thing is, very occasionally, not every time, but you can sometimes find something compressing from the outside, like something like a pulmonary vessels or double
Sagar, can
aortic
I
valve,
tell you,
something.
I beg to, make a comment which I don't know whether I'm correct in evidence based or not. Let me apologetically tell a few of the bronchoscopies for younger. When you start doing bronchoscopies, you will get malicias. That is because that is the easiest to diagnose,
Right.
and there is a floppy airway that you can pick up. Whether this malacia is because of the age and the cartilage matures and you outgrow or not, or whether they persist is a bigger question. Generally, they become better with age. That is one part. Now,
Perfect.
all that I wanted to tell is it is same as somebody does an ultrasound for pain abdomen and finds mesenteric lymphadenitis.
True.
I think the analogy is well understood by many. Do not be guilty if you have a wheeze and you don't subject them for bronchoscopy. Just watch with time, things will be better. Is that okay, Sagar? From both, see, from bronchoscopist's perspective, he as soon as he passes the scope, he should give his findings. One of the findings can be malacia, which is
Right.
often missed. Mind you, malacia can be there coexisting with even congenital heart disease. You start doing bronchoscopy for all VSDs, you start finding more of the malicias in them.
Yes. So I don't want to go into that too much now. I just wanted to highlight, suppose if it is not responding, think about malacia.
Yes,
Okay.
excellent. And if it
Okay.
worsens, all the more you think of Malaysia.
Absolutely. So that's what, because in that situation, your beta agonist won't help you. Okay.
Yeah, in any case, if they don't respond to bronchodilators, look for alternate diagnosis.
Absolutely. So that
Either
is what.
Malaysia or it could be foreign, but it could be something else. Work up. Don't leave there.
Okay. So another question is, um, how to treat continuous coughing, especially happens in night without fever, as wheeze most of the time absent on the day,
If
on day
somebody
one and
has,
two. So what he means to ask is, first 2 days there is no wheeze, only child is coughing at night. How will you treat?
I will tell all the audience that do you agree that now I told you the evolution of wheeze, how we pick up the wheeze, how we miss the wheeze, everything. I think you concentrate on the physiology very well. Now, can you agree with me that the cough is more common than the wheeze even in asthma? Although wheeze is little more specific than the cough. Cough is very non-specific, but wheeze is little specific than the cough for diagnosis of asthma. And therefore, my dear friends, please understand that the cough is more common. And in the cough, if you ask me to qualify the cough, the recurrent cough, cough in bouts, cough responding to bronchodilator, cough associated with the wheeze, cough that happens in the night. That is called as nocturnal cough. And if you have a nocturnal cough, it can be hallmark of asthma. It can also be hallmark of uncontrolled or poorly controlled asthma in an asthmatic. Suppose you have an asthma on treatment. If you start getting night coughs, that means asthma is uncontrolled. Or if it is first time diagnosed nocturnal cough, if you have ruled out postnasal drip or chronic rhinosinusitis, then it is definitely a case of asthma.
Okay. So one more
Sometimes you can
question.
get even in allergic rhinitis also nocturnal cough.
Yeah, absolutely. So another thing is, you have to think about the allergic rhinitis, sinusitis. The another thing is, sir, one patient having some. So question is, a patient is having weight cough for 2 weeks. We give antibiotic, cough syrup. We give combination of levo and montelukast, but still cough is there. X-ray near normal. Can we use steroid for 1 or 2 day or short duration of nebulization?
Okay. This is a good question. Now, I'll tell you when a child will respond to steroids. It will not respond to neutrophilic inflammation or a lymphocytic inflammation. If you have an infection of airway, for first week, you will have neutrophilic inflammation. Second week, you may have lymphocytic inflammation. Third week, definitely you will have lymphocytic inflammation. Did you understand? Therefore, my dear friends, definitely no for steroids in the first week itself. That is absolutely because even tuberculosis will have neutrophilic inflammation to start with. Just because tuberculosis is chronic, it will go for lymphocytic inflammation. And tell me, do we give steroids in some kinds of tuberculosis? Answer is yes. It suppresses bit of, it is anti-eosinophilic, anti-lymphocytic, but it is not anti-neutrophilic steroids. Am I clear? Therefore, my dear friends,
Yes.
if you have a phenotype of asthma, which is eosinophilic, definitely it is going to respond to steroids. If it doesn't respond to steroid, but other modalities of treatment of asthma, like we say nephrotic syndrome doesn't respond to steroids, but respond to immunomodulators, that means to say the inflammation may not be that eosinophilic. That's all is the message. So if it responds to steroids, well and good. If it doesn't respond to steroids, either it is a type of asthma which is not responding to steroids. For example, obesity and asthma, which can be neutrophilic asthma. Is that clear to you? Or it may not be asthma at all.
Yes, sir.
So therefore, my answer to that question is, can I give short course of prednisolone? Answer is no. 5 days of prednisolone is not equivalent to therapeutic trial of 3 months of budesonide. Point number two, you should also ask persistence of cough is not the reason for giving steroids. Suppose if the cough is high, what happens to the cough in an infection? First 2 days there is fever, third, fourth day cough starts, seventh to eighth day it peaks, 10th day it reduces, 12th day it almost stops, 15th day it almost stops. 50% of the cough will come down by 1 week, 90% by 2 weeks, almost 100% by 3 weeks. So therefore, my dear friend, please understand this graph. Just presence of 1 or 2 cough should not make you tempt you to give antibiotics, steroids, or nebulization whatsoever. Just tell them, just take some warm gargles or honey, they will be better.
Okay, so
Continue.
what is the lowest stage to youngest stage where we can start ICS?
You can give inhalation corticosteroids even in newborns. Are we not giving for bronchopulmonary dysplasia, post ventilation, lung injuries, so on and so forth? Answer is yes. There is no age. But the question is whether they will respond. If it is, as I said, what is the purpose for which you are giving ICS? If it is for asthma, until and unless asthma is sure by trial of ICS, which itself will take 3 months, you should have 3 episodes before you give the suspect asthma, or at least have a doubtful asthma, and then decide to give ICS trial of 3 months and then decide. You can give, suppose I have given a trial of ICS at, let's say, at 6 months itself. Highly allergic family, IG was high. Sir, it is definitely asthma, sir. I am 100% sure, 10,000 rupees bets, all these things. Suppose you say, you can give a trial of ICS. Suppose your conclusion is not good, you can give second trial of ICS also, but not more than 2 trials of ICS, and then decide about asthma. Second trial of ICS is also permitted. 3 months you give, take a conclusion, you are not able to conclude for some reasons, you give a gap and then again start second trial of ICS. Before you start like daily low dose steroids, if you have a doubt, and therefore to me, youngest age is not less than an year. I have not diagnosed asthma less than in infancy at all. At least to me, I have not diagnosed. Asthma, straight away I have started long-term ICS. I have not done it below in infants. I don't know about others' experience. I wanted to know because in different areas they may have different types of experience.
So why to call us? Here I will ask you the other question. Why to call asthma in infancy? You can just anyhow you are giving the ICS, right? So instead of calling it as asthma, so it's like a definition. So put it as a
Probable
label.
high probability of asthma with risk factors on trial of ICS. That can be
Yes,
the
that can be
diagnosis.
diagnosis. So not necessary to put that label. Anyhow, so another question is somebody has asked, um, can we
No, for trial of ICS, you cannot give any other drug other than budesonide. No formoterol, nothing. Only
yeah,
budesonide should be
only
given.
budesonide? Huh.
Because you need to know the response to steroids. Suppose if it responds to formoterol, not budesonide, you will not know.
So I think there are no further
And
questions.
this one question, Valry, you can call Valry, Balry, Reelry, whatever. It is just after all lower respiratory tract infection of a viral etiology. Or you have assumed a viral etiology, it could be any other etiology. Just it's a lower respiratory tract infection, febrile, you give symptomatic treatment, treat fever. You may give plus or minus bronchodilator and some symptomatic drugs and send them with assurance based on the severity.
So there are no further questions. I just
Okay.
wanted to conclude this session by saying it was excellent lecture by Professor Subramanya sir, as we call lovingly Subbu sir. And thank you so much, sir.
Sorry,
Uh,
sorry for all the participants. You know,
no,
it's
but
almost 12 o'clock.
but
I was in my tears that all of you are there waiting for half an hour. Pa. For your sake, I'll do one more session with some other plan. Maybe again from Raigad. Maybe
yes,
after 3 months
yes,
or 4 months.
definitely.
Yeah,
So
yeah,
just wanted to conclude that asthma or under five or young bees to say whether it is going to be asthma or not, it's a clinical diagnosis. X-ray is rarely required. Even bronchiolitis, you don't require any investigations in a bronchiolitis until unless proven, or there are other features like high grade fever or something, you can take X-ray. Investigations like for asthma, like as sir said, PFT or impulse oximetry is very rarely required until unless you have to prove something to the parents where and they are not listening to you, and you are in a fear that they might go to some other doctor if you start inhalers. In that situation, you can go for impulse oximetry, which is available now freely. In rare situations like as likely pointed sir, FT like failure to thrive, clubbing, there is a hypoxia which is not consistent with the features of asthma, and sometimes some people do X-ray and there is atypical shadows on X-ray. Think about some other conditions like cystic fibrosis or PCD or any other immunodeficiency syndromes. Genetics, as rightly said, it's only 10 to 25%, but it's all mostly environmental factors that contribute a large. And ultimately, any cough which starts in infancy or early period starts as a dry cough, but then later it becomes wet. So you need not to worry immediately if there is a wet cough starting for 2 to 3 days. And with this, I think he has made such a fluent, even though there were so many internet glitches, but he made so fluently. He made sure that you understood the concept. And I think from this time onward you will start recognizing these patients early, so that you can prevent further future episodes in infants or preschool kids or less than 5 years or any young children with wheeze. With this, I thank you, sir, from my bottom of my heart, and from IAP Raigad team, Dr. Pramod Wankedi, sir, Dr. Hemant Gangulia, sir, and of course, the techno behind us, Dr. Vishal Raut. Thank you very much. Good night, all of you, and thank you for your patience staying back on this platform to listen to sir. Thank you so much. Good night, sir.
Thank you. Good night, Pa. Thank you so much.
Good night, sir.
Bye bye.
Bye bye.